So I'll be talking about this topic, vitamin C saves lives in sepsis. So this talk was given to me as a debate in Vizag on 15th December 2019. So what's the agenda for this talk? So my opponent, as you would know, is this legendary person, towering personality in intensive care. So like in Bhagavad Gita, they say we have to respect our opponent. So I pay my obeisances to my opponent before I go on to tackle this debate. So what are the tools that I would be equipping with to counter our argument? Is I look at physiological rationale for vitamin C. Then we'll just look into what is the basis of administering vitamin C in sepsis and what happens to the vitamin C, endogenous vitamin C levels in sepsis. And we look at, so in this talk, I'll be only talking about mortality as endpoint because the title of topic is vitamin C saves lives. So I'll be looking at only clinical studies which have looked at mortality as endpoint. So there are 3 randomized controlled trials. There's one before and after study. Then there are 2 meta-analyses which favors my argument. And then there are more than 12 future trials that are in the pipeline. So I would be looking at that. So then we'll talk about take-home message and rebuttal. So I think as you would know, so vitamin C, physiologically the way it acts as a cofactor for dopamine B hydroxylase, and this dopamine B hydroxylase converts dopamine to norepinephrine. So the endogenous norepinephrine levels would be low when the vitamin C levels are low in sepsis. So which means you have low vitamin C, low levels of norepinephrine, and more protracted shock. So what basically by administering vitamin C you do is increase your endogenous norepinephrine. That's why many studies have shown shock reversal that happens better when you administer vitamin C. So it scavenges free radicals. So it restores tetrahydrobiotin and alpha tocopherol within the cells, which are useful for cell viability. And most important action of vitamin C is it increases the tight junctions, which maintain the endothelial integrity within the vessel wall and prevent intracellular and paracellular leakage from the blood vessels. I think that is something which is important, protective action that vitamin C confers, because we understand in sepsis there is lot of capillary leakage and there is lot of fluid losses due to vascular and capillary leakage. And by maintaining the endothelial integrity, by increasing the tight junctions, so this capillary leakage could be averted, and vitamin C may be protective to that effect. And vitamin C is also known to have enhance the function of lymphocytes and macrophages. Then the question remains as to why we give thiamine. So what we have understood is by giving increased vitamin C, when there is an increased administration, there is oxalate deposition within the kidneys. So why that happens? Because the glyoxylate gets reduced to oxalate. What we ordinarily want is glyoxylate to be oxidized to carbon dioxide by glyoxylate alanine transferase. And for this, thiamine pyrophosphate acts as a coenzyme. So which means you need thiamine pyrophosphate for oxidation of glyoxylate to happen to convert it into carbon dioxide, and we do not want oxalate deposition. So that's the rationale for giving thiamine in the cocktail. So as you see, so it maintains the capillary integrity. By administering vitamin C, the capillary leakage is averted. And there are studies which have shown reduced vitamin C having good correlation with multi-organ failure and death. And there are around 4 to 5 studies. As you see, there are 2 studies from UK, one from Switzerland, one from US, which shows in sepsis, vitamin C levels are very suboptimally at a very low levels. And they are, sometimes they say it's at undetectably low levels in severe sepsis. So let's look into the studies. So this was a study by Zabet et al. Came in 2016. So from the Iranian group. So it was a small study of 28 patients. So 14 in vitamin C group. So they gave typically 25 milligram per kg 6 hourly. So if it's a 60 kgs, you would give around 6 grams per day, and compared with placebo 14. So they looked at vasopressor requirement. As you see, the vasopressor dosage was significantly less in vitamin C group as compared to the placebo group. And the duration of vasopressor, so they could wean off the vasopressors much effectively in vitamin C group. The duration was much lesser as compared to the placebo group. And most importantly, the mortality. 28-day mortality was significantly less, 14 as compared to 64%. And ICU length of stay, there was no difference. So this is one study which says that vitamin C does indeed save lives. Then let's look at this study by Nathans et al. So this is a US study. So here they looked at vitamin C in surgical patients. So the primary endpoint they looked at was composite of patients developing pneumonia and ARDS. So, but the secondary outcomes they looked at mortality, multi-organ failure, duration of mechanical and ICU length of stay. So this was a bigger study, 595 patients, 301 patients in vitamin C group and 294 in the placebo group. So here they gave 3 grams of vitamin C per day. So primary endpoint, the composite of pneumonia and ARDS, there was no difference between vitamin C. As you see, relative risk was 0.81, statistically not significant. But multi-organ failure, so we could extrapolate the occurrence of multi-organ failure was significantly less in vitamin C group as compared to the placebo, and that was statistically significant. And we could extrapolate multi-organ failure obviously lead to death, so obviously your mortality should be reduced. And ventilatory free days, as you see, the relative risk was 0.7, so it was not statistically significant. It was 3.7 days versus 4.6 days. So the finding that was striking was multi-organ failure, which was significantly less in the vitamin C group. So the Kaplan-Meier, you see multi-organ failure significantly less in the vitamin C group. But interestingly, what we need to appreciate in this study, when you look at the secondary outcomes, they have looked at 28-day mortality, ICU mortality, and hospital mortality. As you see the trends in the vitamin C group, the mortality trends towards being low, ICU mortality tends to be being low, and hospital mortality also tends to being low, although none of these achieved statistical significance. But maybe the number needed to treat may not have been adequate, or the power of the study may have fallen because you're looking at a secondary outcome. So it did not achieve statistical significance. Maybe it is a hypothesis generating that there are trends towards reducing, as you see 4 versus 7, 3 versus 9, and 5 versus 9 with regards to all mortality indices. So again goes on to show there is some juice in this vitamin C in its ability to reduce the mortality. Then this big article came by Marek et al. In 2017, which created a lot of ripples. So he used a cocktail of vitamin C up to around 6 grams per day with thiamine with hydrocortisone. And so these were the results. So this was a before and after study. So it was a retrospective study. So 47 he treated and compared with the historic cohorts. And as you see in the control group where vitamin C was not given, the mortality was 40.4%. And in the treatment group where vitamin C was given, the mortality was 8.5%, and it was statistically significant, p less than 0.001. And in addition to this, they saw that vasopressor could be weaned off much earlier. The duration of vasopressor was much lesser in the vitamin C group as compared to the placebo, and the SOFA reduction, which is indication of severity of illness, was significantly lesser compared to the placebo, and the reduction of procalcitonin also happened much better. And interestingly, what they found is it did improve the renal outcomes also. So there was reduction in the hemodialysis from 33% to 10% in vitamin C group, and that was statistically significant. So you saw the Zabet study, there was a mortality benefit. Nathan study showed reduction in multi-organ failure and trends towards reduction in mortality. Then this is the medic. So these are the three sort of randomized trials. Then so he came out with this cocktail. So Merrick's cocktail, which is vitamin C, and it became a little popular and created ripples across the world that there is some juice in this vitamin C. Then came the newest article, the CITRIS-ALI study. So this came in JAMA in 2019. So this was to look at vitamin C in patients with sepsis who went on to develop ARDS. Sepsis patient who developed ARDS, and they looked at whether it had any bearing on the organ failure, and they looked at whether vitamin C had any effect on the biomarkers of inflammation and biomarkers of coagulopathy or vascular injury. So here they looked at CRP, and they looked at thrombomedulin as an indicator of vascular injury. So it was a double-blinded, multicentric, randomized controlled trial between September 2014 to November 17, 7 ICUs in USA. So 167 patients were enrolled, and vitamin C was administered at a little higher dose because Merrick used 6 grams per day. If you extrapolate 50 milligram per kg for a 60 kg, it would come to around 12 grams. So he gave 12 grams for 96 hours. So the endpoint was to look at change in SOFA from baseline to 96 hours, and CRP was looked at as a biomarker of inflammation, And thrombomodulin was looked at as a biomarker of vascular injury at 0, 48, 96, and 168. So mean age was 54.8 and 54% of them were males. So 167 patients, 84 in vitamin C group, 83 in placebo group. And as you see, after administration of vitamin C when compared to placebo, the levels raised at 48 hours, sustained for around 96 hours and then came down. So the primary endpoint, the change in SOFA from baseline to 96 hours, there's no difference between vitamin C and placebo. CRP, no difference. Thrombomodulin, no difference. But what is interesting to note is that when they looked at the secondary outcomes, 46 secondary outcomes, they found significant reduction in mortality in the vitamin C group as compared to the placebo. That was statistically significant. And in secondary outcomes, they also found favorable effect on increasing ICU free days, which is important at day 28, and increase in the hospital free days. Both of them were statistically significant. So they found three important variables which were beneficial with vitamin C: mortality, ICU free days, and hospital free days. But there were some limitations. So there was a delayed administration of vitamin C. The reason why we say that is they waited for the sepsis patient to develop ARDS, which means the recruitment would have been delayed and the administration would have been delayed because administration would have happened after recruiting. And this study was underpowered for changes in the SOFA and biomarkers, and mortality was not looked at as primary endpoint. And the death and ICU length of stay were dissimilar, especially when they did a secondary analysis, so which raises the possibility of internal selection bias. And as I said earlier, mortality patients were not included in the analysis of Delta SOFA score. And in fact, there was an editorial that came by Merrick which said, had they included the patients who died for the analysis of SOFA, maybe the change in SOFA would have trended towards being significant. So the conclusions from this Merrick's trial was sepsis with ARDS, vitamin C had no bearing on organ failure and biomarkers of inflammation. But having said that, if you look at secondary outcome, so there was a mortality benefit, which again raises the hypothesis that vitamin C may have some bearing on saving lives in sepsis. So these are all the four randomized controlled trials that I said looked at mortality and it had some favorable trends. Now let's look at meta-analysis. So when you look at this meta-analysis which came in 2019 from the Chinese group, so they looked at 12 trials including 1210 patients, and they looked at three categories. They looked at a medium dose of vitamin C which is 3 to 10 grams. So the Merrick's hypothesis that 6 grams, or even Nathan's where he used up to 12 grams, so they sort of come in this. So less than 3 grams he looked at that group, and they looked at a third group which is where vitamin C was given more than 10 grams. What they found is mortality reduction was significant in this sort of a dosage. So when the dosage was 3 to 10 grams, they could achieve reduction in mortality, but this mortality reduction was not seen in less than 3 grams or more than 10 grams. So again goes on to show that vitamin C, as you see in this meta-analysis forest plot, diamond significantly favors vitamin C when it is given in a dose of 3 to 10 grams, and these are all the studies that were taken to conduct this meta-analysis. So that's the first meta-analysis. This is the second meta-analysis which came by Jingli. This also came in 2018 by Chinese authors. So when they did a meta-analysis taking these three main studies, Zabet, Fowler and Merrick, so again they found the diamond moves towards favoring vitamin C. As you see, the mortality reduction was statistically significant, and confidence interval, as you see, is significant with odds ratio of 0.17. And even in this Jingli study, they also found that vitamin C favored reduction in the duration of vasopressor use also. So again goes on to show mortality, although you're looking at as a primordial endpoint, there are a lot of other secondary variables like length of stay or reduction of vasopressor use, and reduction in the dosage of the vasopressor use and reduction in the duration of the vasopressor use was found in multiple studies. So the take-home message at the end of four randomized controlled trials and two meta-analyses is septic patients, we understand they have very suboptimal levels of vitamin C and thiamine, and this may go on to explain many abnormalities in sepsis, predominantly the vascular leakage that happens. So four randomized controlled trial, as you see, showed benefit with absolute no toxicity, and two meta-analysis by a Chinese group shows that there is mortality benefit. So CITRIS-ALI study, as you see, although the primary endpoint did not look at mortality, when you look at secondary outcomes, favored mortality benefit. And as I said, deaths were eliminated from delta SOFA analysis, which is a limitation. So I will just talk about this in our rebuttal. So we did our own study, so that I will show that we did an interim analysis, and I'll show you the results in the rebuttal. So we need to wait for Victor's trial. I understand that recruitment is already done. The results may be out anytime early next year. So we would have to see what these results show. So the rest of the discussion I'll keep it for rebuttal. So I would end my talk with this quote. So मेरा पास विटामिन सी है, 4 RCTs है, 2 meta-analysis है, 12 future trials है. So I would ask my opponent, तुम्हारा पास क्या है? So we'll see what opponent has to say. So that's my side of the argument when I deliberate on this talk against my opponent. So obviously my opponent gave his own explanations, and then my rebuttal. So I would start with this. So thinking is difficult. That's why most people judge. So I think we need to put more thought into the studies that have happened, and and try to give due credence that there is some merit in using vitamin C. And I would say, there's no smoke without fire. So when there are 4 randomized control trials and 2 meta-analyses, which have shown that there are trends towards mortality, and most of them were statistically significant, which means there is some truth to it, and we need to work on it. The reason why I say that is there are 12 studies lined up, which are looking at various endpoints, and most of these studies which are lined up are looking at mortality as an endpoint, which means to say that yes, people worldwide have realized or recognized there is some benefit with this, and they want to establish that benefit. So these are all the future trials, one from USA, and as you see, this Chinese trial, they're looking at hospital mortality as an endpoint. And vitamin C, this is a Slovenian study which again is looking at hospital mortality. Oranges study from USA looking. So why are these studies looking at hospital mortality as endpoint? I think they are basing it based on all the studies which have shown some trends towards mortality benefit. And Australian study is looking at vasopressor free days. This is a Croatian study again looking at hospital mortality. And this is an Indian study which is looking at shock reversal. So what I mean to say is there are 4 to 5 studies already happening which are looking at mortality, so which will probably re-establish that yes, vitamin C. And for the sake of argument, for any randomized control trial, the amount of money that needs to be put is a whopping $72,600 to 169,000, which amounts to 50 lakhs to 1.5 crores for one randomized control. So the world over, there are different countries across the globe worldwide putting so much money. So it means they wouldn't be putting money into something where there is no science. So this is my argument that there has to be something in it for so many nations coming together to put this much of money to do these trials. So one person, my opponent cannot be right to say that there's absolutely no use when there's so much resources being put in to look into the truth of what vitamin C can confer for us. And today we are arguing on mortality as an endpoint, but as this cartoon came up after adrenal trial, so chasing mortality endpoint is a fool's, because in ICU we have stopped looking only at mortality as an endpoint. There are a lot of other variables, vasopressor free days, and the dosage of vasopressors, and your ICU length of stay, hospital, all this have a bearing on patient outcome. Just to argue, yes, vitamin C does not, has no bearing on mortality, and you would shy away, because there are at least 10 studies which I have not quoted which have shown varying other benefits with reduction in vasopressor dose, and mitigate or reducing the duration of vasopressors. So these are the other favorable endpoints that this study has. So I would say when things change inside you, things change around you. So I would ask my opponent, what has he done to see whether vitamin C is absolutely useless? Has he done anything on his end to ascertain, yes, it is useless? So at least from my end, we have looked in our own study. So we pondered about the role of vitamin C, because you can argue that all those studies that I've cited have been done in a population which may not be representative of our population. So we did in our own organization this study. So between January 2018 to February, and I did an interim analysis for the sake of this debate to see whether it had any benefit. So we recruited 86 patients with sepsis and septic shock. So here the only difference is we use hydrocortisone only in patients who had shock, and we used vitamin C and thiamine for all patients with sepsis. And what were our results? As you see, In fact, if you see our age group, if you look at CITRIS-ALI, the median age was 56. Ours are much older people. And as you see, the baseline characteristics, there's no difference, except hypertension was more in control. And even Apache, the severity was no different between treatment and control groups. There's no statistical significance. So we recruited 86. These are interim analysis. So we had 42 in vitamin C and 44 in control group. So as you see, the ICU mortality, although this slide may not be very convincing, but as I said, this is an interim analysis and look at the trends. 19% is the ICU mortality in vitamin C and thiamine as compared to 34.1. Although it has not achieved statistical significance, but you can see the trends, which means we are still recruiting the patients. So once this number increases, we are hopeful that it may achieve statistical significance. And mechanically ventilated free days, we did not get any difference. Vasopressor free days, we did not find difference. ICU length of stay, we did not. ICU length of stay, we did not find. I mean, in fact, it went the other way because control group had lesser ICU length of stay, and hospital length of stay there was no difference. So for the this question, I think my opponent answer would be is Enaku Nilayana Yochanaikal Ullana. So I think the audience can ask him only as to what that means. So thank you very much. So I would end my debate with this. Confusion is better than stupid conclusions. In conclusion, there is still a possibility. In stupid conclusion, there is no possibility. So I would say making stupid conclusions at this stage will not give any room for possible benefits of vitamin C. Thank you very much. You can visit my website www.drpradeeprangappa.com to rehear to this lecture, gain clarity.